Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
Hi again. My name is Q. I'm a fourth-year resident in radiation oncology at the University of Arizona. Just to start off with, I wanted to discuss a little bit more about the field itself. So as many of you already know, oncology is the study of cancer. And cancer is usually suspected by primary care providers, emergency medicine providers, and hospitalists based on clinical presentation, abnormal lab values, and imaging findings. But to ultimately confirm a diagnosis of cancer, someone has to obtain tissue, so either a surgeon or an interventional radiologist, and a pathologist confirms the findings of cancer under the microscope. Treatment is multimodality. Surgeons take care of a lot of cancers by cutting it out. They aim for getting a negative margin. And then medical oncologists take care of cancer either through chemotherapy, immunotherapy, targeted agents, or hormonal therapy. That leaves what I do, which is radiation therapy. And radiation therapy utilizes ionizing radiation. Sometimes it's from a source such as iodine or cobalt, and sometimes it's generated through a linear accelerator or a particle accelerator. These methods are different ways to create free radicals that can destroy the cancerous cells, or they can damage the DNA of the cancer cells, making them have a difficult time dividing and spreading. So regarding radiation, it's very useful in cancer because it's very focal. We use our targeting systems, our mapping systems to localize the cancer and carve out a specific shape of the radiation beam so that only that is targeted and we can spare as much of the healthy tissue as possible. It's also good because sometimes a patient is unfit for surgery, or it's in a place that cannot be removed, or there's some leftover tumor cells after the surgery. So it cleans up what surgery does sometimes. And there's an interplay between radiation and systemic therapy, such as chemotherapy or immunotherapy. Oftentimes, treating cancer requires a combination of the three, and radiation can be used to cure cancer, but it can also be used to palliate cancer, meaning alleviate pain or other symptoms or prevent complications such as a cord compression from occurring. So it does require a medical degree, obviously, and then that's followed by 5 years of residency. I talked a little bit about it earlier, but I did my first year in internal medicine, and then years 2 to 5 are dedicated in radiation oncology. Most of it is outpatient based, so it's a lot like any other outpatient service. You work directly with an attending physician. You see the patient first, you develop a plan, you present to the attending, and then the attending sort of goes over your plan, and we rotate through the different sites of the body. So CNS, pediatrics, head and neck, gynecology, thoracic, skin, GU, musculoskeletal, GI, lymphoma, and rotations are generally 2 to 4 months. And we usually do like at least 2 rotations for each disease site before moving on. It's a very good quality of life. Even during training, we rarely exceed over 60 hours per week, which sounds a lot, but as a busy pre-med, I'm sure you can definitely handle that. And then weekends and holidays are usually off. There's minimal call. And there's also ample time for electives. So if you're really interested in research or learning to do different types of procedures, or even going abroad to learn about machines that other countries have that the US doesn't quite have yet, there's definitely ample time for that. Once out of practice, most people do go into a private or community setting. In those cases, unless they work in a very big institution or hospital, they're usually in charge of treating all sites of cancer. And common things being common, most of a radiation oncologist's practice is breast cancer, prostate cancer, and palliative cases, such as like bony metastases or brain mets. And then the remaining quarter would be like all of the other sites that aren't breast or prostate. It is a very academic heavy field. So 20% of practicing physicians are in academic settings. And the clinical work is pretty similar, except they generally focus on one part of the body. And then subsequently, they do their research and their teaching on that part of the body so that they become more and more of an expert in that specific site. There's generally 5 components to what a radiation oncologist does. The first part is a consultation. We are a tertiary service, so we depend on referrals from other providers, other oncologists and surgeons. And most of the time it's from an outpatient setting, but sometimes there are cancer-related emergencies where our consultation and treatment takes place in the inpatient setting. The next part is a CT simulation, where we begin the treatment planning process. We put the patient in a position that that optimizes exposure of their cancer while also moving other body parts such as the arms. Sometimes we ask the patient to hold their breath. Sometimes we ask them to lay on their stomach so that other organs that don't have cancer in it are out of the way as much as possible. Sometimes even a matter of a few millimeters makes a big difference as far as side effects. After we get the CT scan from that, we do what we call planning. And the first part is contouring, where we draw out the tumor. And then we also draw out the organs we're trying to avoid side effects from. We work with our dosimetrists to come up with a plan that optimizes treating the cancer but minimizes toxicity. And then once the plan is ready, we treat the patient. And treatment can last anywhere from just one day. And really in one day, I really mean like 20, 30 minutes to 20, 30 minutes a day for 9 weeks. It depends a lot on how sensitive the area is and how slowly we can safely go to get away with not causing severe side effects. And then during that time, we also manage their side effects if they come up. And finally, we're very involved in the follow-up of the patients. We're usually the ones who order follow-up scans and manage long-term side effects. And we do what we can to make sure that the cancer doesn't come back. And if it does come back, we can address it as soon as possible. We do everything with precision in a matter of millimeters to even sub-millimeter precision. And we are able to do that through 3 things rather. One is immobilization. So when we treat like a head and neck or a brain cancer patient, we use a rigid mask, which I will show a little bit later, to keep the head still. Number 2, our machines are very precise, meaning they move in the millimeters we ask them to. And not only that, but number 3, they have something called multi-leaf collimators. They're basically rectangles that are just a few millimeters wide that move in and out and create the shape of the beam we want to use to target the tumor itself. So by having multiple leaves that are just like a few millimeters in thickness each, we can create a shape that looks just like the shape of the tumor, and therefore the leaves will shield out the areas next to the tumor. But even with that in mind, we sometimes treat a little bit more than we need to, because a lot of organs can tolerate some radiation and still function correctly, but we would not want to miss and have to come back, and that would be even more toxic for the patient.
Sure.
So I have two different and unique cases to discuss. I'll try to go through them, through the 5 components of radiation oncology I mentioned earlier, but I'll also broaden it out so that it's relevant to future physicians, even if they don't go into radiation oncology. So the first case is a 59-year-old man. He presents to the hospital with a headache, fatigue, and transient blurry vision. On history, he says that these symptoms have been worsening for over 2 weeks. And he says that he has a history of high blood pressure, smoking, he's quit, fortunately, and also melanoma that was cut out a few years ago. So on physical exam, he was found to have a right visual field deficit, but otherwise no other neurological symptoms. So both of his eyes have a blind spot, but it's on the right side of each eye's visual field. So differential diagnosis so far, anyone who presents like that, we have to consider a stroke, especially given his history of tobacco use, his high blood pressure, and also because he does have a focal neurological deficit. It could be an emboli that is blocking an artery that's feeding a part of his brain. But since he does have a smoking history and also a history of melanoma, we should also consider cancer. So the next step would be imaging. In the emergency department, a very quick scan to order is a CT scan of the head without contrast. That helps us rule out acute bleeding, and therefore, if it's a stroke, they can consider things like a clot buster. But anyways, the CT scan was negative, and CTs generally aren't good at picking up fine detail lesions. So next step would be an MRI. Those take longer, but they're a lot more sensitive, and they can pick up very subtle findings. So on this patient's brain MRI, he was found to have 9 different lesions in the brain, both above and below the tentorium, and they range anywhere between 3 millimeters and 2 centimeters. And there are small amounts of swelling, especially near the larger lesions. So the next step, given his history and the findings of the MRI, it's much more likely to be related to cancer than it is to a stroke. And because there's swelling, the next step would be to give the patient dexamethasone, which is a steroid that reduces the swelling, and that should help with the headache as well. Neurosurgery is usually the first go-to whenever there's a new brain lesion. And for neurosurgeons, a lot of their research has shown that surgical resection is helpful when there's one large tumor, but not so much when there's multiple tumors. So they decline to operate. Furthermore, there's actually areas that some of the lesions are located in that are very sensitive, usually in like the brain stem or the deep frontal lobe. It's actually quite dangerous to operate in those areas. So they actually recommended that the primary team consult us in radiation oncology. And usually we're able to offer something because radiation is, again, non-invasive, and it also provides very good local control, meaning the areas that are treated with radiation are unlikely to grow again.
Real quickly, what, this might be kind of an elementary question, but what exactly is a lesion? Is that like just a kind of unknown mass of cells or something?
Yeah, so you're right. Lesion is a very non-specific word. It doesn't necessarily mean tumor. In my field, it usually represents tumor, but we use it kind of as a catch-all just to describe something that's very discrete, that's different from the surrounding tissue. So in this case, it would be a tumor.
Right.
So we do our consultation, and we feel that given the patient's history and the unlikelihood of this being anything but cancer, we do recommend radiation. So the next step would be the second part, which is simulation. That's where we get our CT scan so we can plan it out. And that's done with a regular CT scanner. The only difference is that it's located in our department, and the bed that they lay on is a little bit flatter compared to like a curved CT bed. And because we're going to be treating lesions or tumors in the brain, we have to keep the head still because we don't want the patient to sneeze or even swallow. Very small, subtle movements can make treatment a little bit more difficult. We might miss it, or we might have to use a margin that's bigger than we need to. So we make the image on your right, which is a thermoplastic material. It starts as a very flat mesh. Once we heat it up a little bit, it becomes very pliable or malleable. So we can use that to stretch it over the patient's head. And then we let it cool by fanning it for about 10 minutes, and it stays that shape, in the shape of the patient's head, and it's bolted onto the bed of the CT scanner and later the bed of the linear accelerator to keep the head still. So most patients surprisingly do pretty well. I personally don't know how I would feel if I had to do that, but I know some other providers have gone through this experience just to see what it's like. But we usually try our best to comfort them. We let them choose some sort of nature scene that's just on the ceiling itself so they can watch that. We let them choose their music. And for a select few patients who might have claustrophobia or a difficult time with this process, we have special masks that are a little bit more open. They're not as good as these masks, but they offer a little bit of compromise. Or we prescribe for them like a sedative medication to help them through the process.
Gotcha.
So after we obtain the CT scan from the simulation, we upload it to our planning system. And the first part of planning, as I mentioned earlier, is the contouring. As you can see in the lower three pictures, we've drawn out in the smallest circles where the tumors are. And again, they're located in different parts of the tumor. I can't use 3 images to represent all 3. After we contour, we can actually we have a big decision to make. There's actually 2 ways to treat the patient with radiation. At 9 tumors, there's actually a pretty good chance that there's other tumors that we just can't see on the MRI yet. So one option would be to do what we call whole brain radiation. That's where we treat the entire brain to a low dose of radiation. It will help keep the tumors we see at bay, but it will also treat the tumors we can't see quite yet. The caveat, however, is because we're treating areas that don't necessarily have cancer, there will be higher side effects. And patients do report things like difficulty concentrating or some memory loss after whole brain radiation. Now, our technology has improved such that, as you can see in the top right image, we can actually spare the hippocampi, which are our memory centers, when we do whole brain radiation. So if a patient has a lot of tumors, but none of them are in the hippocampi, we can go with something like C, like the top image on the right. But even with that, there are side effects involved. Now, the other option is we can just specifically target the tumors we can see and perform frequent MRIs in the months to follow and treat the ones that do pop up. The benefit is we avoid unnecessary radiation to the parts of the brain that don't currently have cancer in it, and therefore there's going to be less side effects. But of course, there's the detriment that we might be missing our opportunity to treat something that's there right now, and who knows, it's quite possible that it could blossom and be more difficult to treat later on. So the patient cares a lot about his memory and his quality of life. He's only in his 50s, so still relatively young. And he's also very reliable. He's very agreeable to getting MRI scans every few months afterwards. So he opts for the focus radiation, which we call stereotactic radiosurgery. Stereotactic means it's very focused and precise. It uses a coordinate system to localize the tumor, and radiosurgery is basically just high-dose radiation that provides a control rate, preventing recurrence, about as good as surgery itself. So the next step, of course, is the treatment itself. Once we're happy with the plan, we bring the patient back for treatment. And with radiosurgery, we can actually treat each lesion in one day. And if the lesions or the tumors are close together, we can do all of the tumors together. They do still have to lay there for about an hour, but it's definitely better in his case. He definitely preferred it compared to like coming back for multiple days. So the top left is an image of what a head and neck or a brain cancer treatment would look like. And the bottom is a diagram of how the beams pass by. So the beams go into multiple arcs. You can see the one that's highlighted in yellow. That one starts on the patient's front left and it goes all the way around. The table then yaws or sort of just spins in a different direction, allowing the second beam to pass by in a similar manner. And that way we can get as many approaches as possible so that the excess radiation is shared in small doses to the normal brain, as opposed to some parts of the normal brain getting excessively high amounts of radiation. And when we saw the patient in follow-up, his first follow-up a month later, he did report some fatigue during treatment, but that has since resolved. He denies having any headaches. His vision did improve, but it's still a little bit limited. He came back again 2 months after that for his 3-month follow-up. He denies having any new symptoms, and a scheduled MRI did reveal 2 new lesions, which we were able to subsequently treat. But the 9 that we did treat already stayed the same in size, and a few of them actually shrunk. And the patient is currently on immunotherapy for his melanoma.
Now, what was the significance of the left? Was it the left or the right vision field that was kind of messed up?
Yeah, so that's a great question. So the right visual field is controlled by some pathways that go through the left part of the brain. I'm not sure if I have the exact sequences that show that, but as you can see, there are some tumors on the left side of the brain that could, and this one in particular could be sort of in the back where the processing centers of vision are.
Interesting.
All right, so everyone ready for case 2?
Let's do it.
All right, so case 2 is different, and I think it highlights a different aspect of radiation oncology. So we have another middle-aged man. He's 55. He feels relatively healthy. He presents to his primary care provider for an annual visit. He says he's very healthy. He goes to the gym pretty regularly. The only thing that he's noticed over the last few years is that he's been waking up once per night to urinate. And that's actually quite common in men, so it's nothing to really be worrisome about. A man's prostate does enlarge with age, and that does make the urethra narrow, and that does cause urinary symptoms. Only relevant medical history is that family history is that his father had prostate cancer diagnosed at 74, so almost 20 years older than he currently is. But his father was treated and is currently cancer-free. So the patient really was interested in primarily blood work. So the physician orders usual labs such as a complete blood count, comprehensive metabolic panel, and around the age of 50, 55 is when a primary care physician can talk to his or her patient about getting a prostate-specific antigen screening. So labs come back. His cholesterol is mildly elevated. He agrees to go on more hikes, but it's not quite to the point where he needs like a cholesterol medication quite yet. His PSA is 5.4, which is not excessively high, but it is unusually high for a man of his age. Usually men below 60 or 70, we'd expect it to be 3 or less. So he's referred to a urologist to discuss a biopsy. So our differential diagnosis so far, of course, we have to suspect prostate cancer, and that's why he's going to a urologist. But there could be other reasons for what's going on too. It could be falsely elevated. if he had a recent bike ride or a recent injury to the perineum or recent intercourse, that can actually elevate the PSA just temporarily. And his, as I mentioned before, his urinary symptoms are most likely due to benign prostatic hypertrophy. As men age, the cells in the prostate around the urethra that area tends to get bigger and bigger, and that area constricts, making it difficult to urinate fully, and that's probably what's causing his symptoms. And of course, as I mentioned earlier, prostate cancer, it is the most common non-skin form of cancer in men. So when he went to see his urologist, the urologist performed a digital rectal exam. The prostate was smooth. It felt a little bit larger than men in their 50s, but otherwise no focal nodules, no irregular bumps. So the urologist discusses a 12-core biopsy, which is standard of care. Basically, the prostate can be subdivided into 6 sections, and if a urologist were able to obtain 2 pieces from each section, that's a good sampling of the entire prostate. Once the sample is collected, it's sent to a lab where a pathologist was able to read it. And the pathologist found that 3 of those 12 cores had a prostatic adenocarcinoma. And adenocarcinoma is a cancerous cell of a glandular origin. So prostate adenocarcinoma would be producing more and more of the prostate-specific antigen, the PSA we discussed earlier, and that's what's causing the elevated PSA lab that came back. So fortunately, no more than 20% of each core was involved. The Gleason score came back as 3+3, and Gleason is a grading of prostate cancer. It starts at 3, which is the lowest for prostate cancer. Then it can go to 4 to 5. So a 3+3 is the lowest form of prostate cancer, but it can go as high as a 5+5, which is the highest form of prostate cancer. So based on his Gleason score, his PSA, and the fact that there are no findings on his digital rectal exam, he was found to be a low-risk prostate cancer. For a lot of cancers, we determine their stage based on their TNM, so the tumor, the lymph node status, and whether or not there are metastases. But in prostate cancer, we usually use a risk, low, intermediate, and high-risk prostate. So for him, he had a low-risk prostate cancer. So the urologists are usually well-versed in discussing treatment options for prostate cancer. And I'm going to go over some of the options here. One consideration, although based on his age, physicians should not recommend, is watchful waiting. There are patients, however, who refuse to want to undergo any sort of treatment. Either it's through denial or just a lot of fear of the treatment itself. So we usually don't recommend it unless the patient is very sick and more likely to die from another cause. The second option would be active surveillance. Like watchful waiting, there's no treatment right away, but instead of just letting something cause an issue, we actively do more rectal exams, more PSA tests, and either an MRI or a biopsy every 1 to 2 years. Basically, it's a focused and scheduled regimen of surveillance to make sure that the prostate cancer doesn't become more aggressive. But even in his case, he's still very young. He could live another 30 plus years. So that's a lot of years for the cancer to become more aggressive. So for him, we wouldn't recommend that either. There are a few other options that I didn't list. They can cure prostate cancer, but there's no strong evidence for them. And those other treatments are things like cryotherapy, freezing the prostate cancer, or using radiofrequency ablation. And there's a few other ones too. But the 2 standard options, especially in low-risk prostate cancer, is radical prostatectomy, cutting it out, or providing radiation. Now they both have their benefits and deficits. With radical prostatectomy, it's to aim for a cure, but there are higher risks of erectile dysfunction and urinary incontinence, meaning more difficulty with controlling a patient's urinary function. There could be more accidents. So just to wrap things up, I think there's many reasons to go into radiation oncology. I think there's a lot more pros than cons. I find meaning in the patients I work with. I find a lot of meaning in the families of the patients I work with. And I do enjoy the work I do, not only from an intellectual level, but also from a humanistic level. I get to work because I get to work with them when they feel the most vulnerable. And it's really up to you if you go into radiation oncology, if you want to be very proficient in procedures, or if you never want to go into an OR or touch a tool again, that's totally fine. But it's good in the sense that there's very good quality of life. And, there's very little worry about having to be paged at 3 a.m. or to work through holidays or whatnot. But definitely the biggest pro is the science behind it and the ability to help cancer patients. There are limitations to the field, since it is a field that's relatively small and there's not that many positions. Not every part of the state, not every city is going to need a radiation oncologist. And sometimes the field's just saturated in some parts of the country. So there may be some difficulties living exactly where you want to live and practice, but usually people don't have any difficulties living and working within like a 2-hour radius of where they really want to work. And the other thing is we're a tertiary service, so we don't have any issues establishing good relationships with our referral source, but not being a primary service and not having like our own new patients, we are very reliant on the other providers who are our source of referrals.